All right, we're going to finish up chapter 19 today, talking about the mycobacterium. So, chapter 19 is gram-positive pathogenic organisms. Now, typically, mycobacterium isn't considered either gram-positive or gram-negative. It's usually considered a class all its own called acid-fast bacteria. But they group it here with the gram-positives because mycobacterium doesn't have an outer membrane. All right, so we're going to really refer to them as acid-fast, and again, not either gram-positive or gram-negative. I want to start with the mycobacterium, thinking about why you should care about mycobacterium. So some infections, there's, again, many different species of the mycobacterium, on the order of like 75 different species. We're going to briefly mention two of them and spend a lot of time on the third. Okay, whoops, sorry, hit the wrong button. Mycobacterium leprae is the causative agent of leprosy. All right, so there's a graphic representation of somebody with leprosy. This organism actually grows best at 30 degrees Celsius. So that's why you see the manifestations, kind of the outer limbs, so the nose, the feet, the hands of patients. But it impacts the nerves in host extremities. So lots of disfigurement there. Still around in the world today, but very treatable. Again, if you catch it before it causes this kind of deformity. Mycobacterium bovis causes tuberculosis in not only cows, but elk, deer, buffalo, and they can transmit that bovine tuberculosis to us. So if we, for instance, drink unpasteurized cow milk, then we can get Mycobacterium bovis. It's usually a little bit milder tuberculosis in humans when we get it that way. But again, this is still common in developed countries where they don't pasteurize their milk. All right, but we're going to spend the most time here on Mycobacterium tuberculosis. Of course, this causes tuberculosis in humans. All right, so this in this country, we don't really think about tuberculosis all that much, but it's still a worldwide threat. So I wanted to show you some statistics here from your book. Globally, it's estimated between 1 out of 3, we'll say 1 out of 4, somewhere between 1 out of 3 and 1 out of 4 people are infected with TB worldwide. Okay, so that's a pretty astonishing figure. It kills about 1.7 million a year. Okay, so again, that's a pretty astonishing figure. That's according to the WHO, the World Health Organization, for 2016. Okay, we only have about 10,000 cases in the U.S., so we don't even get a color in this graphic here. It's sub-Saharan Africa that's really the hotbed of tuberculosis, where we have a huge problem. Okay, so we thought that once we came out with drugs in the late 40s that would work against tuberculosis, that we would eradicate this disease. The American Lung Association switched from concentrating on TB to concentrating on smoking, and it hasn't gone away. And we'll talk more about why that is. There's a number of reasons that it hasn't. But it's not an infection that's in animals, so it's something that potentially we could eradicate someday, but now it's looking like that's not going to happen in the near future anyway. All right, TB is a pretty complicated infection. So we're a little bit mixed up. Before we think about virulence factors, we're going to talk more about what the infection looks like first. There are actually 3 different stages of disease. So we're going to start out here with primary TB. Now, it doesn't necessarily, the infection doesn't necessarily progress from primary TB to secondary TB and on to the 3rd stage of TB. So that makes it a little bit complicated. It's hard to diagnose and it's difficult to treat. Okay, so TB can ultimately infect many different kinds of tissue, but it always, I should never say always, but almost all the time it starts in the lungs. Okay, so first of all, it's that this bacilli, this tuberculosis bacilli, is inhaled. All right, so it's transmitted from person to person by respiratory droplets. And it is considered airborne. It's a hard word to spell. Okay, so you don't have to be within a meter of somebody. You can be further away than a meter and you can still catch it. Okay, so it is considered, again, airborne. So again, this picture, you inhale it, the patient inhales it, and then typically it travels to kind of the very ends of your bronchial tubes to those, the alveoli, okay, and targets the alveolar macrophages, okay, so deep within the lungs. And the bacilli actually invades and lives right in those macrophages. Okay, so it starts out, once we have, again, the infection, the prodromal period, you could say, is some mild flu-like symptoms. You know, some tiredness, headache, maybe a little fever, but the bacilli are replicating within those alveolar macrophages. And so the macrophages do present some antigen by both MHC class 1 and MHC class 2. We get some cytotoxic T cells and B cells activated, and in some cases, at this point, the infection is cleared. Okay, and then that patient has been exposed and they'll have, say, antibodies, and we'll be able to detect that they were initially exposed, but their immune system fought that off. And actually, we think that happens a good portion of the time. But if that doesn't happen, if we don't get, again, a good activation by our adaptive immunity, then we get to a state where we get kind of a stalemate between the bacteria and our immune system. So we get what do we call tubercle formation. And a tubercle is basically a granuloma that we have a special name for because we see that pretty often in tuberculosis. It's very hallmark of tuberculosis. Okay, a granuloma is just a mass of tissue formed as a result of some kind of inflammation. All right, so when we have granulomas in tuberculosis, we call them tubercles. Okay, and this is a process that really isn't terribly well understood, but we get some collagen deposited around these macrophages that have, again, the living bacilli in there. And like I said, we get kind of a stalemate between the bacteria and our host immune system. Okay, so here's a picture over here in your book of a tubercle. All right, so these cells here, these are all macrophages, and we've got the bacilli in those cells. These in the center are living macrophages, living bacilli, and then these are probably all dead macrophages for sure. This protein, collagen, that's a structural protein that's kind of been deposited around here. And so we get kind of this walling off, and the bacteria, again, just can kind of sit there and hang out for long, long periods, years and years and years. Okay, the host during this stalemate is not going to have any symptoms. Okay, and the host is not infectious. Okay, in other words, it's a latent infection. And at some point later on in time, usually if the host gets sick with something else, maybe cancer, maybe it's HIV, could be anything, then that can trigger these cells that are alive in the center here to break out of that tubercle. Usually when they break out, this tubercle has gone through a period of caseous necrosis. That's just some abnormal cell death where the center of this tubercle turns to kind of this cheese-like consistency. That's where the word caseous comes from. Remember, necrosis is death of tissue. So at this point, we're going to have live bacteria spilling out back into the lungs. Okay, so once we have these live bacteria spilling out in the lungs, then it's not considered primary TB anymore. It's that's now considered secondary or reactivated TB. Okay, so the tubercle is broken up, and now we've got, again, bacteria out now becoming infectious again. So it's estimated that only about 10% of individuals that have primary TB progress on to secondary TB. Okay, and again, sometimes this is called reactivated TB. Okay, so it's no longer latent. We've got those tubercles rupturing. Stalemate's been broken. All right, so some early symptoms once this happens that we see in the host. They have a productive cough, lots of sputum coming up, maybe some chest pain, maybe that sputum is even bloody. Okay, so that sputum filled with bacilli, okay, easily spread. It's, coughing out into the air. The patient's very infectious at this point. Okay, later on in the infection, okay, some later symptoms, fever, chills, night sweats, okay, appetite loss, weight loss, of course, paleness. For a time in the 1800s, that was all these famous poets had tuberculosis, so they had this pale, ghost-like pallor to them. That used to be, for a time, that was considered really cool to be pale like that. It's also where we get the name the White Death. Okay, tuberculosis is also called the White Death. Patients were very easily became tired. Okay, and with these symptoms, that's where we get the other name that we often hear in tuberculosis called is consumption, because patients were literally consumed. All right, they were exhausted, they were losing weight, they had a fever. At this point, the mortality is about 60% if it's untreated today. And that's probably a little bit conservative considering lots of people that have TB now also are co-infected with HIV. So at some point that progresses into what we would consider third stage TB or disseminated. So it's carried around the entire body by those macrophages via blood and lymph. Okay, so when those bacilli are all around the body, you're going to see signs and symptoms affecting many different organs. So you could see all sorts of damage, like loss of kidney function. Bones are easily bent and broken. Affecting the brain, meningitis. Patients go in a coma. Okay, this is going to be, once you start seeing symptoms like this, 100% fatal without treatment. So without treatment, and even with treatment, probably 30 to 40% at least are going to die. Okay. All right, so at this point, you're getting to the point of no return. Diagnosing TB can be complicated. So we'll spend a little time here on this. Probably most of you at some point in your life have had a tuberculin skin test. So tuberculin is one of the proteins that we can kind of isolate from the tuberculosis bacilli there. So you probably know how this is done. It's injected under the skin. So the protein, again, it's actually, we call it PPD, purified protein derivative. Let's see, so I think it's intradermally is how they say it, under the skin. You have to read it. You have to go back to the doctor's office or the nurse and read it between 48 and 72 hours later, and you'll get a nice area of inflammation there. That's a positive result. But if it's positive, that's just the first step, because it will turn positive if that individual has had a vaccine. It will turn positive if they had primary TB and their immune system cleared it up. It will turn positive if they had primary TB and they have granulomas right now. It will also turn positive if they have active TB, so second or third degree. So there's still a lot of possibilities there. One alternative to the skin test that hasn't seemed to have caught on yet, probably because it's a lot more costly, is a blood test. Okay, and this is actually called an interferon. Oops, let me try again spelling that. Interferon. Interferon gamma release assay. Okay, so if you remember, we have talked about, this is actually type 2 interferon. We've talked about type 1 interferon, which was alpha and beta interferon, in terms of our innate system's strategy to slow the replication of viruses inside of a cell that's been infected with viruses, and to slow that replication in cells around it by cells secreting interferon alpha and gamma. Alpha and beta, sorry. Interferon gamma is different. This is released when a person's T cells have encountered TB. Okay, so basically we, again, draw some blood, and then in the lab we expose the blood to TB antigen. Okay, so let's see if I can write this. So patients' T cells release interferon gamma when exposed to TB antigen. Okay, so we take a patient's blood, expose it to the TB antigen, and then test for the presence of this interferon gamma. Okay, so the nice thing about the blood tests is that if you have been vaccinated, then you're not going to be positive. Okay, so that's actually one of the negatives to actually having a TB vaccine, is that forever after you test positive for the skin test. Okay, but not so with the blood test. The blood test is nice because there's no waiting to read it. They can do it in like 15 minutes. So if either one of these tests are positive, then they typically will do a chest X-ray to look for tubercles. Okay, so let's write that in there. Okay, so if a patient has primary TB and the granulomas, the tubercles, typically the lesions will be higher in the lungs. And if they have activated or secondary TB, then they typically, those tubercles are going to be a little bit lower in the lungs. So even if you see some, white lesions in the lungs there, that still doesn't prove that the patient has tuberculosis. But if a patient has a clean X-ray, then they're in the clear and they don't have any evidence of having, any kind of tuberculosis. So if you're seeing lesions in the chest X-ray, then the third step is typically to look at some microscopy of the sputum. So sputum is not just little saliva that we cough up. It's like the deep stuff from your lungs that gets hopefully coughed up. And we can do some acid-fast staining, like what you did if you're in lab with that procedure. Or you can, a little bit higher tech, some direct immunofluorescence. Okay, so this is where you use some antibody that recognizes mycolic acid, and it's going to be tagged with some fluorescent dye. Okay, so when we do that, only the mycobacterium show up. And that's going to be definitive proof, if you've got those bacilli in your lungs, that you have TB. Okay, they have other methods like using PCR to detect TB antigens from sputum. Again, that's really quick, but it's a lot more expensive, so I don't think that's in widespread use. So who gets TB and how do they get it? Well, like I said before, this is going to be considered airborne. Okay, usually considered being passed by droplet nuclei, so somebody coughing or sneezing on you. Remember, humans are the only reservoir. So this is not a zoonotic infection. There are some predisposing factors. Somebody is more likely to actually get sick with tuberculosis if they are also infected with HIV. Okay, we had a big spike in TB cases in the 1980s due to HIV. Also, if a patient is a smoker. Okay, smokers are more likely to get any kind of respiratory pathogens because their cilia is kind of inhibited a little bit. And of course, there's lots of other things like poor nutrition, alcohol, drug abuse. If you have poor health care access, then you're not likely to get as good a treatment. And of course, it also depends on a lot of other things that we've talked about already, like how large a dose were you exposed to, how close the patient was to somebody else that had TB, things like that all play a part as well. So when you start talking about virulence factors, things start to get real complicated real fast. And there's a lot that we still don't understand about this organism. but we do know that the biggest weapon that we think Mycobacterium has is their very unique cell wall. Okay, so it's considered acid-fast because when we try to stain these organisms, here's an example of an acid-fast stain, like what you did in lab if you are in lab. When we stain these cells, we decolorize them with acid. It's actually hydrochloric acid. And if the cell holds fast to the primary stain, then we consider them acid-fast. So any organism that's not acid-fast gets decolorized by that acid, and then we give them a counterstain so they don't stain the same color. Okay, so a major component of that acid-fast cell wall is mycolic acid. This is a lipid, and it's usually described as being very waxy. So they have these waxy cell walls. We really don't understand, there's no porins or anything in that cell wall, and we don't really understand how things get transported in and out of it. Okay, there's also peptidoglycan in there, like all bacteria, but again, this mycolic acid is a kind of a layer on the outside of that peptidoglycan. Okay, so what role does that specialized cell wall play? We know that it helps them resist digestion when they are phagocytized by macrophages. Outside of a host in the environment, they're much more resistant to drying out or exposure to acid or any kind of disinfectant of any kind. And because it's very difficult, again, to penetrate that acid-fast cell wall, lots of our antibiotics are just whatever, too big or whatever. They just can't penetrate in. So we have a really small arsenal of antibiotics at our disposal. And one kind of interesting thing that's caused by that, we think this long chain mycolic acid, that these organisms are really slow growing because it takes them a long time to manufacture mycolic acids. Okay, so I'm not sure if that's a disadvantage for them. It also, they're very slow to die. It takes us a long time to kill them. Okay. Okay, I think I gave myself a little bit more room here. The only other virulence factor that I think that I'll mention here is cord factor. Okay, and this is a glycolipid, so part lipid, part sugar. We know that it's a component of this acid-fast cell wall for the Mycobacterium, and by the way, all of the Mycobacterium have acid-fast cell walls, but I think that it's only Mycobacterium tuberculosis that has the cord factor. Okay, so we know that this is vital to the virulence of the organism. Mutants without cord factor aren't able to cause an infection. Okay, so we're not really sure the importance of it. We know that because of that cord factor, cells tend to remain attached to each other. So if you look back at that stain we had of our Mycobacterium cells, they all are kind of clustered together in kind of a cord, apparently. We know the cord factor has some role in inhibiting migration of neutrophils. And we know that that helps inhibit fusion of the lysosome with the phagosome during phagocytosis. Okay, so if the lysosome never fuses with the phagosome, then it doesn't release those digestive enzymes, and our Mycobacterium can live quite happily in that phagosome within the macrophage. Okay, so in addition to cord factor, there's some other mechanisms that prevent the macrophage from actually becoming activated, and that can an activated macrophage in some cases is able to do better at killing within the phagolysosome. So there's some other things beyond this, but we'll just mention cord factor for now. All right, how do we treat tuberculosis, and is there a vaccine? Those are the last two things that I want to talk about. Let's think about the drugs that we use to treat tuberculosis. Streptomycin, hopefully that sounds vaguely familiar. That was the first drug to treat that we came out. Clinical trials were completed in 1946 for streptomycin. Remember, that's an aminoglycoside. Generally, that's no longer effective. Okay, if no other drugs aren't working, then we'll give it a try. But for the most part, my TB organism is resistant to streptomycin. Most of the time now, patient is diagnosed with kind of garden variety tuberculosis. They're given 4 drugs all at once for about 6 months. Okay, so this is kind of a lot of writing, but I think I know I remember things better when I write it down, so I hopefully that's not too much of a burden for you. Isoniazid, so those 4 drugs, isoniazid and rifampin, hopefully those sound kind of familiar. Ethambutol and pyrazanamide probably won't sound familiar. Okay, so again, this is 4 drugs. They're typically given in combination, and they all have a little bit of a different mechanism, and that's on purpose to hopefully slow any resistance to any kind of antibiotic. So remember, isoniazid, this is targets mycolic acid. Rifampin, that targets mechanism there is against RNA polymerase. Ethambutol actually inhibits the incorporation of mycolic acid into the cell wall. So we'll say inhibits mycolic acid into the cell wall. And pyrazanamide, we don't really, the mechanism here is poorly understood. This is a drug that's only used for TB, and what we do know about it, that it seems to shorten the amount of time that it's necessary to give the other drugs. So shortens therapy time. Okay. It may inhibit membrane transport of mycobacterial tuberculosis proteins, but again, not really sure about how that exactly works. Okay, so treatment with these drugs is an ordeal. Typically, it takes about 6 months on the drugs. They're big pills, they're hard to swallow, and we have lots of side effects that are common. Things like nausea, headache, tiredness, rash. Okay, so think about experiencing those things for months and, month after month after month. It's no wonder that people, once they start feeling a little bit better, they quit taking their drugs. It's part of the reason we've got such a problem with resistance now. And it's also the reason they often have what's called DOT therapy, direct observation therapy, where somebody comes to the patient's house, watches them take their drugs, and does that every time. Okay, so they're taking a whole cocktail of drugs, every day, handful of pills. So it gets old. It's tough to treat. And that's just for garden variety tuberculosis. Now we have resistant forms of tuberculosis. MDR tuberculosis, that stands for multiple drug resistance. About 10% of new TB cases are MDR. They're strains that are, again, multiple drug resistant. And sometimes they don't know that till they try these drugs and then it doesn't work, and so then they have to try something else. They should be able to test what strain it is from the start. But if your strain of TB is multiple drug resistant, then they try a second line of antibiotics, kanamycin. This is another aminoglycoside, some of the fluoroquinolones, quinolones, I should say. Remember, they target DNA gyrase. They might throw in some streptomycin. Okay, and typically for multiple drug resistant forms, patients have to be on these drugs for 2 years. Okay, and it's about 20 pills a day. Okay, so compliance is rough. It's rough on patients. Now there are even some strains that are considered XDR. That's multiple, or sorry, not just multiple, but extensively drug resistant. That's what the X stands for, extensively. Somewhere between 1 and 3% of new cases are pretty much resistant to the first line and the second line drugs. Okay, so that doesn't leave us with much. There was a new drug out. It was approved in 2012 called bedaquiline. And this is the first new TB drug in 50 years that had a novel mechanism. Okay, this works because it inhibits the Mycobacterium's ATP synthase. Okay, so the Mycobacterium, again, can't make energy. So that's used in combination with other drugs, but again, at this point, we don't have a lot left. What about a vaccine? If we can't treat it, let's prevent it. Unfortunately, the vaccine that is available is not a very good one. My apologies to the Frenchmen that developed it, but it's called Bacille Calmette-Guerin. Again, these are for the people from France that developed it. We abbreviate it and call the BCG. And this is a vaccine. It's a weakened strain, so it's attenuated. Okay, it's actually derived from Mycobacterium bovis. Okay, so it's a strain of Mycobacterium bovis that has lost its virulence in humans because we've grown it up for many, many, many generations in culture in the lab. Okay, how effective is the vaccine? Well, it's up to 80% effective in adults. So about 80% of adults that get this vaccine, it will keep them from getting TB. If they do get TB, it's typically a little bit milder, up to about 50% protection in children. And protection lasts anywhere from 5 to 15 years. Okay, so it's not foolproof. We don't give the vaccine routinely to people in this country. It's more often given in countries where the incidence is higher. We might give it in this country if someone has a family member, if they're living with somebody that has TB, then we might give them the vaccine. Again, if you've had the vaccine, then you're going to test positive for the skin test. So down the road, it makes it harder to diagnose you if you do get tuberculosis. This also does provide some protection against leprosy, a related disease. But we've had trouble developing a really good vaccine because, again, we don't have a good animal model for TB. So it's difficult to imitate it and makes it harder to come up with a vaccine. Okay, so thanks for listening. Next lecture, we'll move on to our gram-negative cocci the Neisseria. Okay, thanks.